Hi, Dr. Grady again. I'd like to discuss with you the outcomes of women who undergo automated breast ultrasound screening. There's a lot of data regarding mammographic imaging and, to a certain extent, digital breast tomosynthesis, but the data on ABUS is more limited. Most of these studies evaluate ABUS imaging in combination with mammography. There are, however, two studies that look at ABUS imaging alone. These are prospective studies specifically looking at screening with ABUS. In the CHOICE study, ABUS screening in young women between ages 40 and 49 is evaluated. In the CHO study, ABUS screening for all ages is evaluated and compared to mammography with tomosynthesis. These two studies are more relevant to what we are doing at EVE. The sensitivity and specificity for ABUS imaging in these studies is comparable to that of mammography alone. Combination screening, as seen in the CHO study, is superior to either technology alone, but the recall rate for combined imaging is higher. Note that the recall rate for ABUS imaging alone in the CHO study is significantly lower than in the Wilczek and Brem studies. This represents technological advancement in ABUS imaging that have been ongoing over the last few years. My current recall rate in Reading is about 2%, which is comparable to centers using the latest ABUS equipment. Almost all the women in both of these studies had increased breast density. In the Wilczek and Brem studies, ABUS is studied as a supplement to screening mammography. Mammographic studies are done on everyone. ABUS studies are done on women with increased breast density or who are at high risk if their mammogram is negative. It is not possible to calculate the sensitivity and specificity of ABUS imaging alone with the study design used by Wilczek, Brem, and Giuliano. This type of study design is relevant to women who undergo regular screening mammography but who are dense or at a high risk of breast cancer and are then evaluated with supplemental ABUS imaging. In all of these studies, combined imaging is superior to mammography alone, even with breast digital tomosynthesis. Next, I'd like to discuss stage reduction with you. Stage reduction refers to the ability of screening technologies to decrease the stage of diagnosis of breast cancer. This is important because all the benefits of screening, including improved mortality, lower cost of treatment, and most importantly, a great reduction in human suffering, come as a result of a reduction in stage at diagnosis. Here are 4 studies that show the degree of reduction in stage at diagnosis that occurs as a result of screening with ABUS. The measurement used here is the staging index, the proportion of diagnosed cancers that are early stage, that is stage 0 and stage 1, over all cancers diagnosed. These studies include the 2010 Kelly study, which was the first study to look at ABUS imaging, the Soma Insight study authored by Dr. Brem, and a reanalysis of Dr. Berg's 2008 Akron study. I've also included a retrospective study that we did in 2017 of 3,200 patients. Symptomatic cancers are reported only in the Berg and Grady studies. None of these studies looked at tomosynthesis. The stage of indexes obtained through mammographic ultrasound alone and the combination of mammographic and ultrasound imaging is compared. Note that the indexes for mammographic and ABUS imaging alone are fairly comparable, whereas the indexes for combined screening are superior. This implies that mammographic imaging and ABUS imaging are detecting roughly the same number of cancers, but the cancers detected by each technology are different. This makes sense since mammography is superior for detecting calcifications that lead to a cancer diagnosis, whereas ABUS imaging is superior for detecting small invasive cancers, particularly in women with increased breast density. Another point here is that although combined imaging is the superior choice in all these studies, ultrasound imaging alone is a very good screening strategy and roughly equivalent to mammographic imaging alone. Any screening strategy is better than no screening. It can be helpful to look at this in a more graphical fashion. This is a stage distribution for women who present with symptomatic cancers. Most of the cancers are stage 2, but there are also a significant number of stage 3 and stage 4 cancers. Stage 0 and stage 1 cancers are also seen. These women typically do not present with a palpable mass, but with other symptoms such as nipple discharge. These are stage distributions obtained from my 2017 paper. The stage distribution on the left is seen for women with symptomatic cancers. In the middle, we see a stage distribution for mammographic screening alone. There are less stage 3 and stage 4 cancers, but more stage 0 and stage 1 cancers. In the screening literature, this effect is referred to as a left shift. ABUS imaging alone, you can see on the right, also has a significant left shift, but here, stage 1 cancers predominate. Again, this is because calcifications are not well seen on ultrasound. So this is what you get when you compare different staging distributions from different imaging strategies. Mammographic imaging alone reduces the number of advanced cancers detected by 34%. The best strategy, however, is combined imaging, which reduces advanced cancer rates by 40%. The interesting finding here is that ABUS imaging alone also significantly reduces the diagnosis of advanced cancers. This implies that ABUS imaging alone is an effective strategy for women who are not willing or unable to undergo mammographic imaging. This also has significance for resource-poor areas of the world where ABUS imaging is more cost-effective than mammographic or combined imaging. Thank you very much for your attention. It's been a pleasure discussing these topics with you. Brendan can get you the references used in the preparation of this talk. Also, if you have any questions, please do not hesitate to contact me. Thank you very much.